So we have a 27-year-old man who was brought to the emergency department after a motor vehicle accident. Well, his BP is normal, tachycardia is there, respiratory rate is high, he has mild respiratory distress, bruises are there on the chest wall as well because of the accident. Best sound are decreased on the left lung base, and the chest x-ray shows like this. Okay. Well, if you look into the chest x-ray very carefully, you must have observed something. What is that? I'll discuss. Which of the following is the most likely cause of respiratory distress in this patient? Well, the answer to this question is diaphragmatic injury. Okay. This patient present after blunt abdominal trauma. There is a respiratory distress and abnormal X-ray consistent with diaphragmatic hernia. What is that? Which I'm going to discuss just now. So before I discuss the question, let's learn some basic concept about diaphragmatic injury. Blunt abdominal trauma can cause, like in this case also, he had a roadside accident, blunt trauma occur, and that caused sudden increase in the intra-abdominal pressure. And this overcome the muscular strength of the diaphragm. Well, this diaphragm and this is increased pressure in the abdomen, and this lead to a tear in the muscle. Let's say this is the diaphragm, and increased pressure occur. So now, because of this, will have some sort of tear. Maybe this tear has occurred. So now we are finding a gap between the abdomen and the chest because the boundary wall between the two is diaphragm, and that has broken. With the result, diaphragmatic rupture, leakage of intra-abdominal content into the chest. Even in our X-ray also, we could see there was an intestinal shadow in the chest X-ray because it has gone into, the intestine has gone into the abdomen because of this reason. Well, so ultimately when this content has gone, there is an increased volume in the chest. So that lead to compression of the chest, lungs definitely, and mediastinal deviation can be there. In our X-ray, we can see intestine in the chest and mediastinal deviation on chest X-ray is seen. Let's revisit the X-ray. Look into this. Look into this. We are getting this shadow of the intestine. We are also finding this diaphragm is raised. We can see even this is shifted to other side. Trachea is shifted to other side. Okay. Well, so now diaphragm rupture is more common on left side. If you have noticed, in our case also it's on the left side because right side is protected by the liver. So that's why it is usually whatever pressure come like this. Suppose this is the diaphragm and this is the liver. Okay, and this area is free. So whatever pressure increases, it's going to put pressure on the left side of the diaphragm, and the likely rupture to happen on this side. So patient can acutely present with respiratory distress. Some patient with smaller rupture may have a delayed presentation with just nausea and vomiting. Point to be noted. Well, elevation of hemidiaphragm of the chest X-ray can be seen. Sometimes the only finding, even in our X-ray also diaphragm was raised, but additional findings are there. We could see intestine in the chest. Small bowel is present in the thoracic cavity, like in our case. Well, we can have better definition by ultrasonography or CT chest, but this if chest X-ray is not clear about it. So these are the additional things, but first thing is always the chest X-ray. Early recognition of diaphragm trauma is extremely important. Why is it so? Because mortality rate of undiagnosed injury and subsequent strangulation of the bowel. Remember, the bowel has entered the chest. Let's say this is the ruptured portion of the diaphragm. Now intestine has gone like this into the chest, but this can get strangulated any time, and that will lead to further problem for the patient. Okay, so but this strangulation can occur in as high as 30 to 70% cases, depending on the extent of the disease. Most patients require surgical repair and exploration of abdomen for other traumatic injuries. Okay. Now look into this lovely picture. You can see this is the hole, and now you can see this has been repaired. Right? So it is a mandatory. Now something more about what happened. Let's see, normally when the patient inhales, the diaphragm goes down, and we exhale, the diaphragm goes up. Now what happened when during inhalation, diaphragm relaxes and diaphragm contracts during exhalation. It's the other way around. Movement is paradoxical. So I was talking to you, you are getting a intestinal shadow in the chest, diaphragm has been raised, mediastinum has been shifted. They're the classical finding in diaphragmatic hernia. Again, one more picture. You can see lovely picture. This intestine going into the chest, stomach and other abdominal vista herniate into left thorax. Left lung will collapse. Right lung get compressed. Look into the trachea has gone to other side. Mediastinum shifted. Trachea deviates to right. Lovely picture to show you all the finding that we can see in any case of diaphragmatic hernia. Now let's look into other option. Tension pneumothorax, unlikely because the patient not hypotensive. In tension pneumothorax, a patient has hypotension and pulmonary vasculature is very prominently seen, and moreover these patients are in great distress. And the classical finding is, but our case is a mild distress. In our case, this cannot be. Moreover, distress increases with each breath. Okay, cardiac tamponade. This occurs if the trauma is mainly in the chest, but it can occur in any traumatic injury. But can it be? In our case, in cardiac tamponade, patient usually has hypotension, but in our case, BP is 112/92, unlikely. Distended neck vein, tachycardia there in our case also, muffled heart sound. But above all, chest X-ray is diagnostic. You can see that globular type of heart, or what we call as money bag appearance on chest X-ray. But now I have a question for you. Write down the answer. Suppose any patient of cardiac tamponade, what type of pulse we can see in a case of cardiac tamponade? The answer is pulsus paradoxus. Okay, with each inspiration, the pulse tend to disappear or pulse become milder, or we can better appreciate by BP. There is systolic fall of BP more than 10 millimeter of mercury. This is the better way to demonstrate pulsus paradoxus. Well, other important causes where we can see pulsus paradoxus are bronchial asthma, COPD, and of course cardiac tamponade. So let's learn more about cardiac tamponade. There is a fluid in the pericardial cavity, and that put a pressure on the heart, which may prevent it from pumping effectively. The blood will not enter the right atrium, right? And because of pressure from outside, the preload will reduce, the amount of blood coming to lung will reduce, amount of blood coming to left ventricle will reduce, and ultimately cardiac output will also be reduced. So this is the classical thing that we get in case of cardiac tamponade. Flail chest typically cause 3 or more adjacent fracture rib, and they rib break into two pieces, break in two places to be more precise. And that creates an unstable chest wall, and it moves in a paradoxical movement with the respiration. The segment tend to contract during inspiration, normally bulge out during expiration, normally they retract. So the opposite movement going on, we call as paradoxical movement is going on. They are not present in our patient, so this is ruled out. Moreover, this you can see in chest X-ray also, you can see fracture of the ribs can be seen, which is not seen in our case. So let's talk about, as I told you, the flail segment will pull in and decrease in pressure while rest in the cage, when the rest of the cage is expanding during inspiration. You can see flail chest. Inspiration, chest goes out, but they tend to go in. Paradoxical movement. And during expiration, they tend to go out when the chest is contracting. Okay. What about pulmonary embolism? They present with periodic pain chest, sudden onset of dyspnea, and usually with a normal chest X-ray immediately. Of course, we can give hum-tum-hum. Okay. In due course of time. And moreover, the presentation is, this the most sudden onset of dyspnea is the most common presentation, and usually in the setting of deep vein thrombosis. And moreover, chest X-ray will not show intestine into the chest wall. So this is, in fact, if I have to summarize, chest X-ray itself is a diagnostic that we are seeing the intestine in the chest wall or in the chest X-ray. That is a conformity that we are dealing with diaphragm hernia. None of the other four options will show intestine in the chest X-ray. Okay, so that ruled out. So this, in that way, the question has become very easy, but definitely we got many more extra points. So friends, diaphragmal rupture is more common on left side because right side tend to get protected by the liver. Patients usually have respiratory distress and can have deviation of mediastinum content to the opposite side, that we can see in the X-ray also. Elevation of hemidiaphragm on the chest X-ray might be sometimes the only finding, and sometimes we can see a nasogastric tube in the pulmonary cavity, may be a diagnostic finding. Okay, if the patient is hospitalized and X-ray has been taken after putting the nasogastric tube. Hello everyone. Now we have a patient who is a 60-year-old man, and he come to you with shortness of breath for the last 5 months. He has a chronic mild mucoid cough, especially in the morning. Shortness of breath initially occurred with heavy exertion or long distance walking. But now he walks only 2 to 3 blocks and he feels shortness of breath. No fever, no chills. The patient has smoked a pack of cigarette for 40 years. He's a 60-year, that means practically whole life. Young age he utilized in smoking. Well, vitals are by and large normal, and even the respiratory rate is 18. pulse oximetry shows 95% saturation on room and 92% on short brisk walk. No respiratory distress. If you in spirometry, FEV1 is reduced and ratio is less than 70%, that indicate it is a obstructive airway disease. Because one difference between obstructive and restrictive is FEV1 FVC ratio. This ratio is more than 70% in restrictive and it is less than 70% in obstructive airway disease. Rather in restrictive airway disease, it may be rather more than 70% also. No significant change is noted with bronchodilator therapy. Okay, which of the following is the effective measure to decrease mortality in this patient? Well, these are the options we have. But before I proceed further, I have a question for you. Write down the answer. What is the significance of this particular line? Write down the answer in your copy. Well, the answer to this question is that it's a case of COPD. Because one difference between asthma and COPD is about reversible. It is reversible in case of asthma, it is non-reversible. That means when we use bronchodilator therapy, this obstruction is reduced or removed, but in COPD it remains. So we are very clear about it that we are dealing with COPD. So these are the options. Okay. Well, smoking cessation is the best method to reduce mortality. Now we are, in this case, we are getting progressive dyspnea, mucoid cough in patients 60 years with significant smoking history is highly suggestive of COPD. As I told you, there is no significant change noted with bronchodilator therapy, which is there in case of asthma, not in case of COPD. Well, we can, and I told you that when we are confirming, we can go by ratio is less than 0.70 or 70%. That is a obstructive airway disease. FEV1 is reduced. Well, now one more thing. I have one more question for you. In a case of COPD, it is more likely, of course, our case is a COPD. We have discussed why it is no effect with bronchodilator. But in COPD, this can be emphysema or chronic bronchitis. Now write down the answer whether it is our case is a case of chronic bronchitis or is a case of emphysema. Write down the answer in your copy. Well, this is a case of emphysema, more likely. The reason being, shortness of breath for 5 months, agreed, but this may occur in chronic bronchitis. Chronic mild mucoid cough, this is a very important because in chronic bronchitis, the sputum is very, very large and it is not mucoid. It's more of a purulent type of not mucoid. There's one difference. But no respiratory distress. Respiratory rate are 18. And the best thing is the patient is a very lean and thin person. This is very, very important point. Not known to 90% students are not aware that emphysema patients are usually thin weight and as compared chronic bronchitis, they are usually obese. And they may have cyanosis. And that's why they are known as blue bloaters. In contrast, emphysema, they are thin people and no cyanosis. And that's why they are known as pink puffers. And one more thing, very important point, pursed lip breathing. Pursed lip breathing, what is pursed lip breathing? Look at my face, look at my mouth. This is the typical pursed lip breathing what you have seen. Now I was talking about thin person. Sometime the patient of emphysema may just come to the doctor with a history of weight loss. Weight loss. The only presenting feature of emphysema, weight loss. Definitely a patient of weight loss come to you. You like to investigate for thyroid. You like to go for thyroid function tests, maybe tuberculosis, maybe some cancer, maybe HIV. They are the usual common causes where patient can have weight loss. Definitely you have to investigate, but remember, emphysema patient can come with weight loss. So this also goes in favor of emphysema, not in favor of chronic bronchitis, which are obese. Respiration are 80, not distress, and best sound are decreased throughout. Not a very common finding. Sometimes you can make a bronchi also, but one thing is very sure that we are dealing with a case of emphysema. Well, smoking is the single most important risk factor for COPD. That's well known. And the patient has smoked a pack of cigarettes daily for the last 40 years. And that's why his airways have been totally destroyed. Well, now it is seen, suppose there is one patient with COPD, and if he stops smoking, it is shown to decrease the rate of decline in FEV1. At least it will have a break on the further decline of FEV1 and decline in mortality also. Well, it's just like a car is moving very fast and you apply a brake. Definitely the car will slow down. Exactly same thing. Patient is smoking, patient stops smoking, so the rate of decline of FEV1 and will be reduced and mortality will be reduced. Is a single most effective measure to decrease mortality in this patient is stopping or cessation of smoking. Let's look into other option. Option A and C are inhaled steroid and oral steroid. Inhaled steroid, they are shown to decrease the number of COPD exacerbation. They improve quality of life, but they don't have any mortality benefit. Similarly, oral steroid, they are useful as a short-term basis for acute exacerbation of COPD. And our patient doesn't have any acute exacerbation, he's perfectly all right, there's no problem, even respiratory rate is just 18 and there's no distress. These have no distress, they don't demonstrate mortality and they don't have any benefit of mortality in reducing mortality in acute exacerbation. What about long-term supplemental oxygen? Well, long-term supplemental oxygen, LTOT or lung reduction surgery, LVRS, they have shown mortality benefit in specific subpopulation. Well, I'll talk not only about LTOT, this is long-term oxygen therapy, this is what we call as. I'll also talk to you regarding lung reduction surgery and lung transplantation. Now, as far as LTOT, long-term oxygen therapy, it reduces mortality, and quite possible some of you may have gone for this answer, but it is a very tricky question. This demonstrates significant hypoxemia, SpO2 less than 98%, or 89% with right heart failure or erythrocytosis. But in our case, it was 95%. And even after exertion, 92%. So this criteria is not there. So that's why this is not the option. And so they will not have any extra mortality benefit in this because he has only mild hypoxemia. So as compared to cessation of smoking, this is less effective, but cessation of smoking is definitely effective in reducing mortality. Now, as for a lung volume reduction surgery is helpful in which type of patients? Write down the answer. Well, lung volume reduction surgery, they are useful for hyperinflation, heterogeneous distribution of disease, FEV1 more than 20% and a normal PaCO2. That, okay, these are the people where we can use, and patient having bulle. Okay, this is useful. And as far as lung transplantation, it is useful for diffuse disease, FEV1 less than 20%. It was more than 20%. And hypercapnia, here it was normal CO2. Associated with pulmonary arterial hypertension, then these are the suitable candidates for lung transplantation. What about prophylactic antibiotic? Sometimes we use in COPD exacerbation. Prophylactic antibiotics are rarely used in chronic COPD management, not used. We can use in acute, especially in the setting of acute bronchitis. They may decrease the frequency of exacerbation in select patients with frequent COPD exacerbation, but there is no mortality benefit of using any prophylactic antibiotic. So in summary, we can use in acute exacerbations, especially in acute bronchitis, but not a prophylactic drug. Golden line to remember: smoking cessation is associated with mortality benefit and reduced progression of disease in patients with COPD. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.